signs and symptoms can happen due to deposition of cholesterol. Xanthellamas, this is the yellow cholesterol deposit that can also found around the eyes. They typically appear as yellow patches or plaques on the eyelids. Another sign that some people can have is corneal arcus, which is a whitish or grayish ring starting at 6 o'clock position. It appears around the cornea of the eye. This is also a common sign of high cholesterol. Tendon xanthomas. These are fatty deposits that accumulate under the skin, appearing as nodules or bumps. They can occur on various parts of the body, including elbows, knees, hands. Then, because of the high cholesterol in the blood, they can develop premature atherosclerosis, which can cause angina or heart disease, and the aortic valves can be affected, also causing aortic stenosis. There is a criteria that is used by the clinicians for diagnosis of homozygous familial hypercholesterolemia, in which the three genes that we look at are LDLR receptor, ApoB, PCSK9, and LDL-RAB genes. So this is just basically going over all the signs and symptoms of the homozygous familial hypercholesterolemia. Now, what should I do when I find out that I have HoFH? The most important thing to start is have your family tested. Cascade family screening identifies new individuals with FH. When one person in the family is diagnosed, it's crucial for parents, siblings, and children to get their cholesterol checked as well. Even children who belong to the family with homozygous FH should have their cholesterol checked as early as age 2. Although the universal recommendation is to start checking cholesterol between the ages of 9 and 11, and again between the ages of 17 and 21. But for these children, for belonging to these families, should have the cholesterol checked at age 2. Now, what is the genetics of HoFH? So how is HoFH inherited? So if it is a homozygous familial hypercholesterolemia, both parents have heterozygous FH. So the probability of having either homozygous or heterozygous is that every child has a 1 in 2 chance or 50% chance of inheriting one altered gene, which will cause heterozygous familial hypercholesterolemia. There is a 1 in 4 chance, 25%, of inheriting 2 altered genes, which will cause homozygous familial hypercholesterolemia. There is also a 1 in 4 chance, 25%, of not inheriting any altered gene. So these patients are offered genetic testing, and which is still offered and is not mandatory to diagnose homozygous familial hypercholesterolemia. But the benefits of genetic testing are that it confirms the diagnosis. A positive genetic test usually indicates higher risk. A positive genetic test may improve and inform treatment, and it can also improve family screening. So if we find a gene in, then for the rest of the family, we do the targeted screening for that gene. Now let's talk about the treatment options that's available for this. So your doctor, the lower the LDL or the bad cholesterol is, it is better. So your doctor will talk to you about the goals of therapy, and usually it is either to prevent not to develop any cardiovascular disease or those patients who have developed already have cardiovascular disease, there's a different goal. So there are treatment goals for adults as well as for children. These are, and we try to reach them with all the possible medicines that are available currently. Diet and exercise is important. It can bring your cholesterol about 15 to 20% down, and a patient should reduce saturated fat to less than 7%. They should avoid trans fats. A high soluble diet is advised. Also, a dietitian referral is important because she or he can go over diet in detail. Regular exercise is very important. Usually, these patients will not have one problem only. There might be other risk factors. And to lower the overall risk is also important, like controlling the blood pressure, blood sugar, if they're smoking, to stop smoking, and to have a healthy weight for the patients. There are medicines available, and they are the common medicines like statins, which is the first-line therapy. Ezetimibe, this is also a pill. Bile acid sequestrants, these are the type of medicines that have been there for a long time. And recently, PCSK9 inhibitors, which are injectable therapy, is also available as an add-on. There are two medicines that are used only for homozygous FH patients. These are available in United Arab Emirates. One of them is lumitapide, which is used for adults, is a tablet, and it works by reducing the production and release of cholesterol from the liver and by reducing the absorption of cholesterol from the gut following a meal. And this is added on top of the other medicines if the cholesterol is not controlled. Evinacumab is another medicine which is given via monthly infusions at the doctor's office. And this can be given to children aged above 5 and also to adults who are diagnosed with homozygous FH. Lipoprotein apheresis is a type of a dialysis machine that only removes cholesterol from the body. Depending on the level of the patient, it is done either every 2 weeks or once a month, but it is also safe during pregnancy. The last resort that some patients have to choose is liver transplant as a surgical option, but that is done in very rare cases. There are future treatments coming up that looks promising. One of like oral PCSK9 inhibitors, and gene therapy is also something that is very promising because it would mean either 1 or 2 treatment, but still it will take some time before we have start using it. Now I'm going to talk to you about a case of homozygous FH, the first case that I came across. And this was a 44-year-old female who was referred to our lipid clinic, and she had high cholesterol, vitamin D deficiency, and obesity only. She was referred because her cholesterol was still above 200 or 5.2, despite being on the maximum dose of rosuvastatin and ezetimibe 10 milligram. These are the 2 medicines that we use. Her genetic test was offered and done, and it was positive for autosomal recessive hypercholesterolemia. So, I mean, if you look at her, we have a cholesterol with that of such high levels, which is not coming down. So we used PCSK9 inhibitor injections. For this patient, we are using 3 injections or 420 milligrams every 2 weeks. Then we were able to get for her lumitified in the country. And after starting that, if you look at her, LDL has come down to 1.57. So treatment is important, and you can only treat once you find them, once you diagnose them. And this runs in the families. So this is where cascade screening is important. So we have to find, we screened her parents. So because it was, when we checked cholesterol for the parents of a positive case, we call it reverse cascade screening. But then we also checked the blood test for her children and for her husband. And we found, if you look at it, how many patients with one case. That's why cascade screening is very important for patients with homozygous familial hypercholesterolemia. I would like to end my talk here, and I would like to thank all my patients, my staff, and all of you for joining me in helping to raise awareness about this rare, life-threatening condition, which is treatable. We can make a difference in the lives of these people. Thank you all. I would also like to, in this journey since 2017, there have been a lot of local and international experts who have helped me and supported me. So I would like to thank them a lot. Thank you for joining us.
Thank you so much, Dr. Sara. That was very good, especially for non-medicos like me to get an insight into what HoFH is, especially since it's such a rare occurrence. And you're one of the few physicians trained to be treating it. Now is the time we can start taking questions. We have one hand up. Munder, you have a question. Please feel free to unmute and speak, or if you have a question and if you would like to type it for anyone else, please feel free to do that.
Yes, thanks, Krupa. Thank you very much, Doctor, for the very insightful presentation. And honestly, this is actually only recently, like a couple of weeks ago, when Krupa was working with the team on the press release and the news, I got to learn about HoFH, although I am diagnosed with chronic cholesterol for the last 3 years. This is the first time I hear about it. Now, my question is it just the two types, either this or that, or is there is an in between? Because initially, when I was diagnosed, doctor, with high cholesterol 3 years back, I've been told by my parents, actually, when I was tested when I was a teenager, I was like 15 or 16-year-old. The doctor actually said I have high cholesterol and my parents should actually watch out. But honestly, it slipped and I was never like was taken care of until like my early 30s, when I actually got tested and I found out that my cholesterol is skyrocketing and I actually need to be taking medications. So does that mean I had HoFH, or does it mean that there is another type?
No, so thank you for that question. So the thing is that the cholesterol level is what makes a diagnosis. So if it is a child and the cholesterol is above 4 or 160, or in an adult LDL level above 190, that is what familial hypercholesterolemia, the phenotype is. So, but sometimes it also depends on your diet also. But usually at a younger age, and nowadays with obesity epidemic that's going around, a lot of the diets and everything is also causing very high levels. Sometimes, so usually, does your parents have high cholesterol? Were they treated for
Yes,
it
both
when they
of them
were young?
actually. Yes,
So,
both of them.
so that's why for your case, what I would suggest is that you should, I mean, I would like to know, you can contact me later. We would like to know the cholesterol levels, and perhaps we can offer you genetic testing and to see if, so for homozygous FH, usually the disease is very severe. And even in children. So they have some stigmata. I showed you some. Do you have any of that? No.
Not really, no. Yeah.
So I'm not sure whether you have, but that's something I can help you with in the clinic.
Mundar, we should definitely arrange a catch up for you with Dr. Sara after this.
Definitely, yeah. Thank you very much, Dr. Sara. Thank you.
Dr. Sara, we have one more question on the chat box from Samya. She asks, what are the earliest signs or symptoms that we should watch out for?
So in children also, the xanthelasmas, the tendon xanthomas, those are the things, the cholesterol deposits that are there. Some of the children can present with the family history. So the most important thing is also family history. So if the parents have a positive family history of very high cholesterol, of having heart disease at an early age, so then we can and look at the level. So level of the cholesterol plus the family history is what, along with the signs like xanthomas or xanthelamas, can make your diagnosis. So usually, a lot of people, sometimes the first time they present is a heart attack. So some of my young patients who are reluctant to say, because it does not cause any symptoms initially. So that's what they ask me, why should I take a pill if my cholesterol is, if I don't have any symptoms? So it's very difficult for me because it is a cumulative effect. That's why even with heterozygous, these people will have heart disease at their early 30s or 40s. And so that is one of the signs that unfortunately, sometimes that patients presents with.
Thank you, doctor. I hope, Samya, that question is answered for you. We have one more question, Dr. Sara. We have Ali who's raised his hand. Ali, please feel free to unmute.
Yes, doctor. Thank you for your presentation. Just I have a question. You mentioned maybe 4 genes affect the hypercholesterolaemia. The patient inherit variant from his father, like for the LDL receptor, from his mother for the PCK9 inhibitor receptor, and then he has both copies from different gene. Is it considered still homozygous or heterozygous? This is my first question.
No, if he has 2 genes which are abnormal,
Yeah.
that's always homozygous. Heterozygous is only
it's a different variant from different
right.
genes,
They
not
are
the
known
same
as
gene.
compound heterozygous. So compound
Yeah.
homozygous. So 2 genes, as long as 2 genes are abnormal, if you would, sometimes they are at 2 different locations. The same gene at 2 different locations also can happen. So that is homozygous. With heterozygous, there is only always one gene which is altered.
Another question: do you have any dash for, let's say, cardiovascular disease for those patients with homozygous below age 20? Because other factors, they are very low age-wise, so it will maybe reduce the risk. I know the LDL is so high, but age, smoking, other factors maybe make the risk is not going very high. Is there any data showing? No, there is many diseases that are being cardiovascular disease very early, below 20 or 25.
I'm sorry, you're breaking up, Ali. Can you?
I mean, to develop the cardiovascular disease is not only maybe the cholesterol, maybe there's other factors like smoking, age, other inflammatory conditions. So, I mean, those patients in childhood, really, do we have data showing that they are developing, even only cholesterol is high, other risk is low?
So from what I understand, the question is that only if cholesterol is high and there are no other risk factors, is that what you are asking?
Yes. Yes.
So usually if the cholesterol, and these people are usually not obese with a homozygous FH. So usually if there are other risk factors are not there and the cholesterol is very high, the level of above more than 400 is what makes a homozygous FH. So their levels are really high. But if they have other risk factors, we should try to treat those risk factors also.
Ali, does that answer your question?
Yes, thank you.
Okay.
That is so high and is enough to develop cardiovascular disease regardless of other risk factors. If there's other risk factors, this will make it more worse.
That's right. The overall risk will worsen.
Thank you for thank you for that question, Ali, and thank you for that answer, Dr. Sara. We have one more question. It's from Gurfan, who writes from Pakistan. He says, in Pakistan, we only have statins and ezetimibe for HoFH, and after use of 1 year of these medication, there is no improvement, and liver enzymes are increasing. Now, doctors in Pakistan suggested for liver transplant for my 6-year-old daughter. Is this the only option for HoFH?
So in Pakistan, besides this, nothing is available. Liver transplant, I know, is being offered for this as a surgical intervention because perhaps if it is not getting better, she will develop with such high levels, if not improving, she will develop coronary artery disease. So it is important that you should talk to your doctors, and if that is the only option there, you should go ahead. So it all depends on the region in the world where you are. So if you are, I mean, it's just that it's unfortunate that we don't have, and that's why, we are trying to raise awareness so that as a global community, we are trying to get all the treatments available in almost every places. But you're right. I mean, unfortunately, there are not a lot of options there for that.
Thank you, Gufran, for your question, and best wishes from all of us for, and we hope quick recovery for your daughter. We have a couple more questions, Dr. Sara. We do have time, so we can take them.
Sure.
There's one from Dr. Tahira Khokar from Health Plus Family Medicine. She's a consultant. And she asked, what is the threshold level for LDL-C for genetic testing, especially if family history is not known? Adopted parents died young due to alternate causes. Is it covered by insurance, and where do we send these patients in Abu Dhabi?
So okay, that's a very good question. The phenotype, like for adults, the LDL above 190. In children, the LDL level above 160. So above 4 point, and if you're following the British system, it's above 4.9 and above 4. So those are the threshold levels for probable having FH, and if you don't know the family history. Now, genetic testing is available. It is covered by insurance. For UAE nationals, it is covered. For private, depending on what insurance you have, I'm not sure how much it will be covered. So, but it is being offered at Imperial College London Diabetes Center. I do run the clinic over there, also the lipid clinic, and you can send your patients to me, and will be able to do that for them depending on the insurance. Sometimes we can also work and try to get a lower price if the insurance is not covered for genetic testing.
Thank you, Dr. Sara. Dr. Tahira, hope your question is answered. And for any more queries, feel free to write to us at the marketing team or to Dr. Sara directly at Imperial College London. We have more questions coming in, Dr. Sara. There's one from Samya again. She asks if there are any support groups or resources available for families dealing with HoFH.
So that is what we are trying to do. We are trying to establish a support group for our HoFH patients. FH Europe has been working on it, and in the Europe, they have all the organization, and in fact, we are trying to work with them to try to establish one here. But at the moment, there are no support groups, and it is a very private disease, I get, because it's a genetic disease, and people are not open to talk about it or to share, and that's one of the hindrances we have. But we are working on it to start a support group for homozygous FH patients.
I think
Thank
that
you.
brings us to the end of the question, all the questions, and lots of thank yous coming in from our side as well. Dr. Sara, thank you so much for that very insightful presentation. Thanks to all the participants who've joined us today to spread awareness for this very rare disease. And we hope everybody's benefited from the session.
Thank you so much, everyone. Thank you, Krupa.
Thank you.